I appreciate everyone joining us tonight. We're discussing this seminar regarding patient selection for PFO closure. It's sponsored by Gore and Associates, and as it's a sponsored discussion by industry, it technically isn't eligible for CME. However, it's still educational nonetheless. I am Jason Day. I'm a stroke neurologist at Baptist Medical Center. We are a comprehensive stroke center certified by the Joint Commission up in Jacksonville, Florida. We serve the area in several miles, hundreds of miles north. We can't really serve the east because that's the ocean, but sometimes we do get people overseas too. We have a good reputation for our neurosurgical and our spine, our stroke, and several other subspecialties, cardiovascular. We also have an active cardiovascular lab, physicians that are able to perform these procedures. I've been fortunate enough to speak for some other industry companies as well, Medtronic, Abbott, Portola, now Alexian, and Gore. This is my first post-COVID talk. The other ones were live and in person. It was always somewhat fun to go to a different city and see how their hospital systems were organized. And I feel like I'm talking to myself, but I know I'm not. Today, we're going to have a few objectives. We're going to review the subtypes of stroke, including cryptogenic stroke. We're going to discuss the diagnostic workup used to find out the stroke. We're going to discuss the rationale for long-term cardiac monitoring, and we have a case to review regarding that. You will experience random acts of pontification from me. Every now and then I'll go off the rails and talk about something that pertains to how we would treat patients. Unfortunately, if you were to Google to pontificate, it actually means to share your opinion in a pompous way. So you'll have to tell me at the end if that's how it came across when you get the survey by email towards the after the talk. We'll define what patent foramen OVALE is and its association with cryptogenic stroke. We'll introduce this risk of paradoxical embolism score to help triage which patients have a higher risk PFO. We'll review past and present literature regarding PFO and stroke. And we'll finish the cases with cases that were referred for PFO closure. So stroke is an emergency. It's an emergency just like heart attack. But what's different about heart attack, well, stroke tends to actually have one of two ways. It can be a hemorrhagic stroke from the beginning, where the blood vessel actually ruptures, or it could be an ischemic stroke, where the artery is occluded. When the artery is occluded, it can be occluded from several different mechanisms. One is atherothrombotic, where there's an actual clot coming from an artery at risk, or a ruptured plaque that recruits clot right there. Or cardioembolic, which could be material from the arch or the heart. There are some other causes. And then we have this underlying questionable unknown cause called cryptogenic, which is defined as a stroke, an ischemic stroke, occurring in the absence of any obvious mechanisms such as AFib, heart disease, large artery stenosis. It accounts for 1/3 of our strokes, and possibly 1/3 of these patients have AFib the longer you look on the monitors. If we wind up looking at stroke itself, the stroke pattern, where it is in the brain, can actually predict the mechanism in some cases. So if you have an infarct picked up on MRI in one small structure in the brain, that could be a small vessel stroke. The same conditions that would affect the retina and the kidneys, these microinfarcts in one vessel territory. Imagine if a blood vessel was a caterpillar's body and the leg was a small perforator off of that. These would be the arteries of the small perforators. Or the stroke pattern could be small, but in several territories. And depending on its pattern, we could start to predict, could it be coming from a plaque in the chest? Could it be coming from a paradoxical embolism in the chest? Could it be a hypercoagulable state? And in general, if it's a very large cortical stroke affecting several territories, one or the other, that might be the pattern for atrial fibrillation. And the longer and the harder you look for stroke subtyping, you might be able to expand and reduce some of these categories. So cryptogenic may actually really be this small when you finally have done a full workup. Paradoxical embolism, of course, is one of them that we'll be talking about today. At our institution, we have a flow sheet and a power plan. We use a power chart program. And if we notice here, if you have a stroke and we diagnose it on imaging, first we do blood vessel imaging to find out if there's any diseases of the arteries. We also do a workup to look at the echo, the cholesterol, and the A1C to look for medical reasons. If the stroke is a small vessel stroke in one area of the brain, we would consider that a small vessel hypertension. Those patients probably get antiplatelet therapy, hypertension prevention, etc. If the stroke is in more than one territory, we would consider that embolic. If the stroke is in a territory of one artery relative to another, that might be worth repairing for secondary prevention. If the stroke's in several areas of the brain, left, right, up, down, front, back, all at the same time, if blood vessel imaging suggests the blood vessels are irritated, maybe it's a vasculitis or a vasculopathy. Sometimes a lumbar puncture or an angiogram might give us a better picture of each artery. If they have AFib, we would have the answer, like we would use anticoagulation. If they have valve disease, we would have cardiology give us an idea, could that be the culpable source? If we find the PFO, which we'll discuss also, that could be worth a TE and a structural heart consult to possibly close the PFO. And then finally, if it really is still cryptogenic, we can look and see if they need an extended cardiac monitor. Let's do a TEE in case the surface echo didn't show enough, and that might show a PFO the more you look. Structural heart consults, hematology consults, and hypercoagulable screens could finally complete the picture of what type of patient you had. So the benefit of a loop recorder in patients with a cryptogenic stroke could be that these loop recorders can pick up atrial fibrillation in some patients. The loop recorders have a higher yield than just doing an EKG or 7 days of EKGs or a 30-day event monitor. And stroke pattern could predict whether AFib is present, but not as well as finding the AFib itself. So long-term monitors could be one way that we find mechanisms of stroke in some of these patients. So that brings me to this case. This is an 84-year-old female with conventional risk factors, coronary artery disease, or peripheral artery disease. One morning she woke up with paresthesias, EMS was called, and she had problems speaking. I highlighted this date of in September. This was a day of maybe a week before she had a faint, a true syncope. Her vital signs were as such. Ultimately, her stroke scale was a 4. The stroke scale is a National Institute of Health stroke scale. It allows us to determine the severity of stroke and standardize our communication. If someone is paralyzed, cannot speak, and has a gaze preference, those stroke scales are usually double digits, 15 to 20. Left hemispheric strokes, where language is primarily stored, has a higher stroke scale by default because language carries the most points. But in her case, she had an aphasia without hemiparesis, which would be language problem, but not paralyzed. And that would be why her stroke scale is a 4. And we can also predict where her stroke would be based on this. She's right-handed, so we would know this is probably a left hemispheric problem. And since the stroke is only affecting language per se, we would know it's probably at the edge of the brain, whereas if the stroke was more proximal, it should affect paralysis. And that's what this study showed. On our stroke workup, we have a CT and a CT perfusion. Head CT is mandatory to rule out whether it's a hemorrhage or not, given that 2 out of 10 patients in the Western Hemisphere is a hemorrhage. This is why you can't quite give an aspirin in the field until you have a CT, because you don't know which mechanism, what it is, hemorrhage or ischemia. In her case, her head CT confirmed it was ischemia. Her CT perfusion, what this does is it allows us to look at the blood supply to the brain. And when there is a blockage in the brain, the amount of time it takes for blood to get through the blockage is measured in this color map. If it takes more than 6 seconds for blood to get through that side of the hemisphere, it is coloring the map as a green. That is an area of the brain at risk of stroke. Fortunately, in her color map here, she doesn't have an infarct yet. This map here is a cerebral blood flow. And if the cerebral blood flow is 30% or worse, the other side, relatively speaking, that would be considered irreversible ischemia. So this patient has a blocked artery affecting this and her language, but it hasn't fully infarcted. Her scans did say there's a competing cause for her stroke. There was about a 50% left cross stenosis and a 40% right cross stenosis, which makes sense because she has peripheral artery disease. And this is her blockage right here, this flow gap where the arrow right here is the blockage. The blood getting around it could be collaterals, or maybe it's not fully blocked. And one of the controversial mechanisms of treatment would be if you have a occluded artery, you have a stroke that's developing, but it's not fully developed all over the brain. Could we reduce or get rid of this clot? Endovascular wise, you have to come up the groin into the arteries, get all the way up here, navigate past the M1 segment, get in the M2 segment, get to the M3 segment. Next thing you know, the catheter is smaller or larger than the artery you're in, and you can't get there. And so her case, we wound up using heparin. And heparin, after 3 days, opened her artery. And this is the only infarct that she had. And if we go back to the perfusion suggested it was going to be this big, but it turns out it's only this dot here at the end that she was left with because we were relatively successful. Now, I was thinking in her case that she had a condition that did respond to anticoagulation. So here's random acts of pontification number 1. Back in 2017, which yes, I have been practicing for a decade and recertified. It's hard to believe I've already been practicing for 10 years. In 2017, there wasn't any first evidence that would suggest that anticoagulation for stroke of unknown cause was not proven. It was conjectural that anticoagulation for stroke of unknown cause could have an added advantage while you sort out the reason for stroke. But since that time, a couple of studies for embolic stroke of undetermined source, or ESUS, have shown that empiric anticoagulation may not be more effective than antiplatelet over a 1 to 2 year period. But in this person's case, I did choose to empirically anticoagulate, and she wound up getting a loop recorder. And by December, this is 3 months after that faint we talked about, she had 6 months of AFib. And I thought to myself, I'm so glad I put her on empiric anticoagulation. Now, what if I had not, and I left her on aspirin? We don't know exactly when a clot forms when you have paroxysmal AFib. We just know that AFib is associated with stroke. We know that there's an atrial cardiopathy and maybe a clot can form in the tissue, even though there is no AFib at the time. We don't know if you have the AFib coming and going, and that's when the clot forms. But you can have this scenario play out in your mind. If we had only done antiplatelets and 1 week of rhythm monitor or a month, we would think that she was fine. But then what if on December 20th, 2017, she had another stroke? We would wonder the mechanism, and we hook her back up to monitoring, and there's no AFib. We found the AFib because of the monitor. We'll just move on to PFO, patent foramen ovale. It's a primitive structure that we all have when we're developing. When we're a fetus and we're scuba diving in mom, we're underwater abyss style, and we can't breathe, and we're floating around, and our oxygen comes through the umbilical cord and the transfer from the placenta. And you have all this right-sided oxygenated blood in the fetus that gets up to the heart. The lungs are under high pressure because they don't work, so pulmonary artery pressures are high, and blood shunts through this atrial hole between the right and left, allows the oxygenated blood to get the left side of the heart and go to the rest of the body and develop the fetus into us, into a full baby and so forth. Well, eventually when you're born and your lungs start to reduce its resistance because it actually works and can oxygenate, the hole will close, and everybody but 1 out of 4 or 5. 25% of our strokes occur in patients less than 60, and it could be that half of those patients have a PFO. So PFO is thought to be one way a stroke could be generated. Now, there had been some trials of closure that did not work. This slide summarizes those: the Closure 1 trial, the RESPECT trial, which was the initial 2.5 or 2.1 years follow-up, and then the PC trial. They were negative for closure. One reason they could have been negative for closure was patient selection. These researchers came up with the risk of paradoxical embolism score. They took some data that was assumed, if we start from the beginning, that PFO remains open in 1 out of 4 or 5 people. If the prevalence of PFO in patients with stroke of unknown cause is roughly 40%, approximately half of those PFOs would probably be incidental. They then used these databases from here to come up with this ROPE score, which is based on these findings. The likelihood of a PFO being present was decreased by being older, decreased by having conventional risk factors like diabetes, coronary disease, hypertension, decreased by having dyslipidemia, decreased by being a smoker, decreased by having a prior stroke or TA, and decreased by having a small stroke. This regression analysis shows the inverse relationships we just mentioned. The researchers took this data and came up with a 10-point scale to help risk stratify which PFOs were pathogenic and which PFOs are more likely to be present. You would get points for not having diabetes, smoking, hypertension, and prior stroke. You would get a point for having a stroke at the edge of the brain or cortical. You would get more points if you're young. And the ROPE score could predict the prevalence of PFO in those patients with stroke of unknown cause. And the ROPE score was not necessarily related to the prevalence of PFO in those with the stroke of a known cause. So if we take the prototypical patient who gets all 10 points, it would be a young patient, less than 30, no risk factors, a stroke at the edge of the brain, they would have 10 points. Whereas if you have a chain smoking, fungating, diabetic foot person that has stents in every body part, over 70, and they have a small vessel stroke, they'd have no ROPE, their points would be 0. And that correlates down here in the bottom. The higher ROPE score patients were more likely to have a PFO present at all, and more likely that the PFO was the cause of the stroke. One other caveat would be the higher ROPE score patients did have a lower 2-year risk of recurrence, and that's expected and explained because the conventional risk factor individual with low ROPE scores have higher risk of recurrence because their risk factors are still present. So one would take home from this, okay, high ROPE score people have a pathogenic PFO, but they still have a lower risk of recurrence. That is true, but they're also younger patients, similar to the unruptured aneurysm studies, where if you have an aneurysm that's unruptured, that may have a risk of annual rupture of 2% a year, but you're only 35 years old. That 2% per year of rupture of that aneurysm is present for the next 70 years of your life. So if you have a PFO with an estimated medical risk of recurrence approximately 1.5 or 2% a year, you could consider that risk there every year, unless you decide to treat in some way. The trials that were negative, we summarized above. Now the trials that turned out to be positive for PFO closure are down here at the bottom. The GORE study had roughly a 77% reduction of stroke with closure compared to antiplatelets. The CLOSE study had a 97% risk reduction. And the longer-term RESPECT studies, after the 2 years that were not quite significant, became significant after 5 years, had a 45% risk reduction. And we'll get to some mild summaries here. So Closure 1, one of the negative ones, probably was negative because it allowed small vessel stroke and patient selection. RESPECT, after 5.9 years of median follow-up, there was enough strokes in the medical arm where PFO closure became advantageous. So this would almost prove the point that if PFO stroke recurrence is low, well, the risk is cumulative. So there was a difference the longer the person lived. Subgroup analysis did suggest a large shunt in atrial septic aneurysm may have benefited more from closure. And admittedly, there was less benefit in the subgroup analysis of the medical patients that were anticoagulated, but the numbers were low. And we can discuss that as well on whether anticoagulation is inferior or superior to PFO closure. It hasn't been really randomized, but we can say PFO closure has been superior to antiplatelets. And I still have some thoughts on that, and we can open the discussion later about that. The closed study, which was 97% risk reduction, where there was no strokes in the closure group, 6% in the medical group, had such a dramatic risk reduction because they only enrolled large shunt patients, which was defined as having more than 30 bubbles crossing into the left atrium within 3 cardiac cycles after you got the bubbles placed in the bloodstream. Also, atrial septic aneurysm. The Gore study enrolled mostly larger shunts, although 18.1% of the shunts were small. It had embolic strokes only, no lacunar strokes, 77% reduction. And now keep in mind, again, over the 2, 3 year, 4 follow-up, the trials, all of them had a low risk of recurrence, but that risk is still cumulative. So some of these authors and opinions would say it's now reasonable to consider that the presence of PFO and a big shunt should no longer result in the categorization of a stroke as cryptogenic. And then the respect authors, on the basis of completed trials, PFO closure combined with antiplatelet therapy is an evidence-based treatment for young and middle-aged patients with PFO who had a cryptogenic stroke. The closed authors, pending further data on anticoagulation, because it's unclear if that's truly inferior. We believe that PFO closure is the most effective treatment for reducing the risk of recurrent stroke in patients younger than age 60 who have a PFO-associated cryptogenic stroke. And then the Gore study, the consistent benefit of PFO closure over medical therapy alone has been shown in Gore-reduced closed respect trials, thus providing solid clinical data to support PFO closure in practice for appropriately selected patients. So briefly, the references of the slides we just went through. Now we'll do case reports. This is a 65-year-old female that had a hypercoagulable condition from a diagnosis of a DVT and PE, was put on an anticoagulant back in 2012. History of sleep apnea, rheumatoid arthritis, hypertension, migraines, and she presented with aphasia, and she had MRI showing the evidence of the stroke here in this back part. 3 weeks before the stroke, she had a left hip replacement. She resumed, though, that anticoagulant 3 days after surgery, but it's possible that the dosing of it may have been variable when she was in rehab. Stroke workup for her hip. Stroke workup ruled out any obvious large artery reasons, nor were there any new DVTs on lower extremity ultrasound. Her TE showed a normal EF and intracardiac shunt. And her surface echo showed this, and the TE showed that there's a mobile interatrial septum, and it was positive for the shunt. So here's the picture here, the bubbles. And then here is a mobile interatrial septum, and there are bubbles going on in, and they're going to go to her left posterior MCA and cause her stroke. And then in the cardiac cycle, it closes again. So right here, this thing is opening in a hypercoagulable patient. She was referred for closure. She was referred for closure because our hypothesis was, although it's unclear if closing a patient that already needs to be anticoagulated adds any extra benefit based on data and guidelines, with a link I have later in the talk. Our rationale was, what if she has another hip done? What if she has another surgery? What if she gets a dental procedure and you stop anticoagulants? Anticoagulants prevent recurrent clot, but do they prevent all the clots that are small enough to go through a PFO? Keep in mind, a PE is big enough to cause a symptom, but there might be microscopic clots that the lungs dissolve that we never know about. But you only need a very small clot to occlude an intracranial artery. So that could be one rationale to close PFO, even if a patient has clotting conditions that require anticoagulant. These anticoagulants aren't perfect. And for as long as there is a small clot and a hole, it could consider that it could cause stroke. Now, here's a case of someone that you hear the story from the ED and you think you already know what they have, but you're not right. This is a 34-year-old female, history of migraine and visual auras, and she lost all of her vision, had her headache. And I was like, well, that sounds like a migraine. But this aura was different. Her prior auras would take the entire vision and it would return together. What was different was that despite her visual loss resolving, she had a field cut that persisted. She couldn't see my half of my face relative to her right visual field. So what made this different was an aura that didn't completely clear. And that's why this wasn't just a migraine aura, it was different. Her MRI showed infarction in the what pathway of the temporal lobe. The where pathway is higher up in the parietal lobe, and the what pathway is in the temporal lobe underneath. So people don't know exactly, quote, what they're looking at. And also facial recognition and all that's in the inferior part. Now, all that kind of makes sense. Her workup ruled out any large artery lesions. Hypercoagulable labs were negative. The surface echo showed evidence of a shunt. Dopplers were negative. Invasive echo showed that she had a PFO and an ASD with a bidirectional shunt. Last case, a 46-year-old female with hypertension had an abrupt nausea, vomiting, gait impairment. She didn't have any long track findings or paralysis. MRI showed a stroke in the right cerebellum and the right posterior inferior cerebellar artery territory, which if you look at the MRI, the person's laying on their back, looking up through their feet. This is their right cerebellum. And this is the territory of the right inferior cerebellar artery affecting the structures, nausea and vomiting and so forth. Her workup was interesting. CTA could not see the right vertebral artery segments, artifact collaterals. So we have a young person with conventional risk factors with a one artery stroke in one territory, and we're starting to think this could be atherothrombotic. Her surface echo didn't show a PFO, but we asked our neurosurgeon colleagues to confirm CTA's question, and there was nothing wrong with the right vertebral artery, and there was an incidental 3 millimeter aneurysm. So we have a patient that has still an unexplained stroke despite an aggressive workup and a negative echo. We moved on to get a TEE. That showed the PFO. Her other risk factors were rather negative. A1C, not bad. LDL, nearly perfect. This was her echo. This is the right atrium. Right up here is the left. And this is a 3D rendition of you sitting in the left atrium. And here are two bubbles in your left atrium. You are these bubbles. Where are you going to go? Are you going to go to the foot? Are you going to go to the spleen? Are you going to go to the brain? And this is the view of these bubbles crossing as the right atrium collapses during the cardiac cycle. Her hypercoagulable screen had non-pathogenic variants in this gene. 30-day event monitor had sinus rhythm and no AFib, and ultrasound was negative for DVT. She did have risk factors, obesity, and contraceptive medications. And our structural heart doctor asked for a transcranial Doppler with bubbles. And that's when you're insunating the left and right MCAs. You do a peripheral injection of agitated saline, and you can see these bubbles show up into the brain. And that's outlined here. This was the person's baseline without injection, right MCA, left MCA. And then roughly 5 seconds after this minute, they inject. And within 7 seconds, you see these blips, these lines. Some is artifact, but the computer counts it. These lines going all the way through, those are bubbles in the brain affecting the ultrasound probe. And then more time goes and you see the bubbles on the left or the right MCA, left MCA, over time. And so this is now 17 seconds, and this is 12 seconds after injection, bubbles in the brain. And then if you have someone bear down, you might get a few more because you're increasing the shunt dynamics. But again, each one of these lines are the bubbles in the MCA. And just in case you weren't exactly convinced that you saw what you saw, let's inject again. Bubbles are back. So this was pretty convincing that she had a pathogenic PFO that was enough to change, to cause a cerebellar stroke, no large artery disease, and TCD was confirming a shunt, and the echo showed the shunt. This was literally word for word the note that I had for her in the office. I appreciate visiting you today. We discussed stroke of unknown cause, but also discussed PFO-associated stroke, and we showed a video from the industry describing one of the devices that can be used to close PFO. Your recent reclotting had been reduced by stopping the hormonal contraceptives and when you quit smoking 8 years ago. But microscopic clots can still be present, and PFO closure has been shown to be advantageous to prevent recurrent stroke, more effective than using antiplatelets. Technically, PFO closure has not been proven to be more effective than blood thinners or anticoagulant. However, patients would require the anticoagulant for lifelong. PFO closure may prevent lifelong requirement anticoagulation. Okay, pontification point 2 or 3. If the event reporter was to show AFib, then PFO closure may not be as advantageous. That's why you're doing the monitoring. I wrote for Plavix with aspirin, as is typically used together after the PFO closure. So in conclusion, one could say that PFO should be closed in patients less than 60, strokes at the edge of the brain, and a large shunt or atrial septal aneurysm. AA guidelines actually outline some of these assumptions. They state that PFO closure in patients older than 60 may be considered for closure, provided they have a very limited degree of traditional vascular risk factors and no other mechanism for stroke detected following a thorough evaluation, including prolonged monitoring for atrial fibrillation. And the practice recommendation regarding the size, the shunt size. Clinicians may inform patients that the presence of a large shunt probably is associated with a benefit for closure. Conversely, there probably is less likelihood of benefit in patients with a small shunt or a non-embolic single small deep infarct, and is uncertain whether atrial septal aneurysm in the absence of a shunt, large shunt, influences likelihood of benefiting from PFO closure. And then you might conclude, well, PFO shouldn't be closed in a small or no shunt or no atrial septal aneurysm or patients with a small vessel stroke. In the reduced study, 18.1% of the closed PFOs were small. The shunts were small. It was determined, though, that these patients did show the same benefit as the larger shunt patients. Per the AAN, again, it's uncertain whether atrial septal aneurysm in the absence of a large shunt influences any benefit from closure. Regarding Kuhner stroke, there's probably less likelihood of benefit in patients with a small shunt or a non-embolic appearing single small deep infarct. PFO closure may be offered to young patients that have a small stroke with a large shunt if there's any risk factors that are not present that could have led to the small vessel stroke in the first place. And that summarizes what I was, my slides. Now, I was going to briefly show the practice parameter. Through the hyperlink, you would come eventually to this clinician setting. And some of the things we discussed were here, and the different levels of evidence are outlined in the full article. The PFO closure, age 60 to 65, if they don't have any other risk factors. PFO for patients that have a small stroke, but they're young with no other risk factors. It's a shared decision-making between clinicians and all the physicians to match patients' preferences, risk of recurrence, and so forth. And it helps outline some of your thoughts when we look through that. So from there, I think I'll stop and see how the questions come.
Dr. Day, we do have a question that came in. The question is, in the first case, you mentioned the patient had AFib for a couple minutes. Over what amount of time did they have the AFib?
It was 6 minutes on the monitor, and it was captured 3 months after all the strokes and the syncopes. It is still controversial how much AFib is enough. Some trials actually had 30 seconds count. I would say, though, that many cardiologists would agree 6 minutes is the minimum of being enough. I would say any AFib, because I always want to have an answer. I'm tired of the 1 in 3 likelihood of not knowing the answer. So if I find something, even for a second, I want to call it that.
Great, thank you. A couple other questions. What is the adequate amount of monitoring to rule out arrhythmia? Do you recommend event monitoring or loop recorders?
Absolutely. And even if the person's over 40, there might be a higher rationale for using a loop recorder while you are figuring out if the PFO is pathogenic. You can always do it simultaneously, where you could close the PFO but still have a loop recorder. Because the PFO only stops paradoxical embolism, it won't stop left atrial clots if you were to get one. And the amount of time for monitoring, the European guidelines for cryptogenic stroke and PFO, I had some slides that took them out for sake of time, talked about like at least 6 months. And I believe somewhere along the way in the practice advisory, they do talk about heart rhythm monitoring. They don't exactly say how long. It says here, patients considered for PFO closure thought the risk of AFib should have cardiac monitoring at least 28 days. Risk factors for this AFib include being older, hypertension, obesity, sleep apnea, big atrium, elevated N-terminal BNP, premature atrial contractions, increased PFO dispersion. Recently published guidelines for AHA and cardiology, Heart Rhythm Society recommend prolonged EKG monitoring for cryptogenic stroke patients older than age 40, although more research is needed to define the yield in unselected patients and for how long.
I have another question here. If you have 3 million beats monitored over a month and have 7 beats of AFib, would you attribute that to AFib or PFO if there was a significant right to left shunt? What would you do in that case?
Well, a tree falls in the woods and no one's there to hear it. I probably, based on the age, I probably would lean towards the side of the PFO. Now, if the person's 80 years of age, I'd be leaning towards the AFib.
Okay, we have another one here. Echo, be it surface or TEE, can miss PFO, especially if bubbles are injected via upper extremities. It is important to inject from either left arm due to the prevalence of persistent left SVC, or from left leg vein due to eustachian valve directional blood flow along with Valsalva. Small versus large defect based on crossed bubbles definition is not correct and is shown in studies outcomes as you stated. Does your practice consider specific plans for IV access for bubble studies?
Not routinely, but one of our structural heart doctors that joined the faculty in the last 3 months, he believes we should be injecting from the lower extremities because it's exactly mimicking the fetus.
And I just had a few other questions here. For patients over the age of 60 that seem appropriate for closure, do you do additional screening? And if so, what?
Well, yes. If they had no other artery that was the mechanism, so we couldn't exactly call it a large artery atherosclerotic stroke, I would probably, in parallel form, pursue atrial dysrhythmias while working that up. And I actually can deviate something on the age. We had a patient that had a open heart surgery, and 3 days later wound up having a cerebellar stroke, or 3 days after surgery was discovered. And I had hypothesized it was perioperative because you have, I think this patient was in their late 70s. And I was thinking it was perioperative because people don't really know about their cerebellar stroke until they get up with rehab. You don't always notice it. And we didn't have any knowledge of any PFO at the time because the cardiac workup was surface echo, no bubbles, and it was just coronary artery disease treatments. And my assumption was if it was a medical associated stroke, a surgery associated stroke, then the therapy is you don't need any more surgery, your risk would go down. But the patient had a second stroke in rehab. Fortunately, he's practically asymptomatic. And that second workup involved echoes with agitated saline, and the person had a large PFO, and he was closed. And he has a loop recorder as well. I actually think retrospectively, I agree, because if you think about the surgery being hypercoagulable, zapping all these arteries so you don't bleed out, and then you are kind of immobile and go to rehab, and you have 2 strokes 3 days after, and then 12 days after, or 14 days after surgery, I think it really was possible it was a PFO associated stroke, although there was no obvious lower extremity clots found. And so that's a case where someone is well over 60, competing causes, but we have done a loop recorder, and I've told the patient that we've closed one possibility. If there's any remote chance that we misidentified the real cause, hopefully the loop recorder will tell us.
Great, thanks. Another question here. If a patient had a stroke that was due to paradoxical emboli, but they have a hypercoagulable disorder and require anticoagulation, do you still consider them for closure?
Yes, and the reason why would be the assumption that not every clot can be prevented. Now, yes, there is a case down here, one recommendation in patients who would otherwise be PFO closure but need to be anticoagulated anyway. We should counsel patients that the efficacy of closure in addition to anticoagulation cannot be confirmed or refuted. I have a patient that has what they call a triple positive antiphospholipid, winds up having the beta-2 antibodies, winds up having the lupus anticoagulant and the anticarlipin. She had recurrent strokes on one anticoagulant, was eventually switched to the old-fashioned warfarin, given that that's mostly what's in the literature for triple positive lupus anticoagulant. She has had a left posterior parietal stroke in early October and had some scattered strokes in May. The transition to warfarin occurred after the October strokes. She has, if you remember our eponym, she has a Gertzmann syndrome, difficulty with dyscalculia, difficulty with math or calculations. She had problems navigating the hallway exactly where the elevator is, so maybe some right-left confusion, but doing well despite all the pieces of stroke in her brain. I'm referring her for a TEE because I know that they can still have arterial spontaneous clots coming from that side, but what if it was all venous hypercoagulability with 4 strokes, maybe 5 on the MRI, and failing at least one anticoagulant? She's someone that if she was to have a TE, and I believe some evidence suggests that surface echo misses PFO, I don't know, 1 out of 5 times. I wonder if we really know. I have to look that up. If she had a PFO on TE with the hypercoagulable triple positive antibodies, lupus anticoagulant, and she's had 5 strokes, I would really consider closing it because anticoagulation hasn't been enough for her.
Thanks. Do you always do LE duplex in patients with PFO and stroke? What are the guidelines in this regard?
I'm not sure there's any particular expectation. We do it, a lot of it is under the assumption, well, if we find a clot, we already would use anticoagulant. And how would you rationale all this, speaking out of your left and right ear, saying, well, we would still close a PFO? You could also rationalize it this way. If you have someone that would have a DVT and a PFO and you're going to anticoagulate anyway, if they were to have a recurrent stroke, despite effective anticoagulation, that could be your theory on the PFO closure. It's hard to navigate a wire in the to get up to the PFO if you have a clot as well, at least one proximal. But we do, although I can't think off the top of my head if there's any mandatory reason to. I'm kind of reading through these guidelines here to see if they say anything about it. I'm not sure I see any words of lower extremity ultrasounds right now. Nothing on Control F.
While you're looking for that, we do have another question here that's come in. Are there any criterions for using one device versus another for PFO closure? Do you feel that there are any advantages of using one of the devices versus the other in certain scenarios versus different scenarios?
Not necessarily. I think that's mostly operator dependent. If you have a structural heart physician that trained under one versus the other, some might believe it's easier to navigate one over the other. I usually leave the discussion on which of the two and for how and what anatomy to the structural heart physicians.
Another question, have you thought of adding TCDs with bubble to your stroke workup, as 1 in 5 can be missed on TTE?
Yes, in fact, that triple positive story, I just thought about thinking, well, I'm going to subject her to an invasive TEE, someone on warfarin, when I could have just done a TCD with bubbles. But I felt that you would still need the TE if the TCD bubbles were negative, were positive, I should say. I would say if you have a negative TCD screen, that could be rather compelling that you don't have a pathogenic shunt. That's probably a good idea.
Great, thank you. We don't have any additional open questions at this moment.
Well, good. I guess we can probably conclude our discussion. I again am very appreciative of everyone who tuned in to listen and go through this discussion. And at the end, there will be an email from Gore, a survey for you to fill out regarding how you thought of this pontificating discussion. And I appreciate all of your time.